Hello, everybody. Turloughs is my name, one of the paediatricians in the children's practice. And apologies that I could not be there today to give this talk. But I've made this short video just to go through the talk, and more will be able to answer any questions that you might have in relation to any of the things that we discuss here today. So I suppose I always start at the very beginning and the birth of the baby, and your baby will be when they're born, the baby will often be quite blue, will be quite floppy when they come out. This is not unusual, abnormal. The baby sometimes need a little bit of stimulation just to get them breathing, and certainly after that you find that the babies pick up and start to do very well. They need very little intervention to turn them around. They're quite resilient little babies. As they've been squeezed through the birth canal, they recover quite quickly. So that's the first thing I would say. Often it's quite a distressing situation and a worrying situation when you see this blue floppy little baby come out, but it's completely normal. The vast majority of times babies will be in that situation when they are born. What we do then is we give babies a bit of time to settle into their new surroundings and to recover from the birth situation, and to let them develop their lungs as they start using them to survive, as opposed to surviving off the placenta in the womb. And once we do that, we give them the day one check. And that is a head to toe check on the baby to make sure that they are okay. And this is the first time that a baby's been examined by a doctor, so certainly we're looking for any congenital abnormalities in the baby, what's normal, what's abnormal. And just to give you a flavour of the things that we look for, starting at the head, and this is our little baby here. So we'll start at the beginning, and we will have a look at the baby and decide whether there's any abnormalities. So we start off with the head and the head shape, and the baby's head shape will not be normal, rounded in this normal fashion immediately after birth. Babies have, especially if they've been born vaginally, they'll have been squeezed through the birth canal. So it's very normal for them to have an abnormal head shape. In fact, they look a little bit like a cone head when they are born initially. And that is because the skull is not a fused single bone. It is a series of plates covering the brain. And what happens is the brain grows and pushes out the plates, and then the plates grow back together. And then the brain grows and pushes out the plates, and the plates grow back together. And that's what we want to see. That's what allows the baby's brain grow so quickly in the first 2 years of life. So what we're feeling for is we're feeling for the soft spot where the bones meet. We're feeling for the gaps between the bones and make sure they haven't fused abnormally early. And as I say, the shape will change over the first couple of days. So we look, and people often wonder, if I press on the soft spot here at the front of the baby's head, will that do any harm to the baby? Well, there's certainly no vital structures anywhere near that baby's head at that point, so you won't do any harm to the baby by pressing there. So then moving on down to the ears, we look to see that the ears are normally formed and that they're roughly in line with the eyes, we can see little dips and out pouches in front of the ears. The biggest change that has happened in the last couple of years is the availability of newborn hearing screening. So what we do is we're able now, in a newborn baby, in the first few days of life, we're able to put a probe into that baby's ear and pick up whether the nerve is hearing that noise. And then that allows us then check and see whether that baby has nerve deafness. And nerve deafness is something that's seen in 1 in 1,000 babies. So a significant number of babies every year are born with nerve deafness. And this is a very useful early check to see what can happen, see what the hearing is like for a baby. And this check allows us to intervene and put in cochlear nerve implants into a baby so that they can hear normally. So the reason we screen early is that there's an intervention. Previously, we would have just done the baby checks at 7 months, where we would have the baby sitting on mum's lap and somebody would make a noise off to the side and the baby would turn to the noise. And the reason we do that at 7 months is that that's the first time that we can reliably expect a baby to respond to a noise and turn to it. So for the length of that time, for 7, 8, 9 months of age, we're missing the fact that this baby has nerve deafness. So this newborn hearing screening test is very useful. It allows us intervene appropriately, improve that baby's hearing, and obviously then improve on their subsequent academic achievement and their social interaction and so on. This is done in a number of maternity hospitals. It's done in our practice as part of the new universal newborn package that we offer for babies. So these are very worthwhile tests to be done. The next thing is moving down onto the eyes, and really the babies at this age, they won't really pick up on, they won't smile at you, they won't respond to your face at this stage, but we're looking to see that when we shine a light into the baby's eyes, that we can see into the back of the baby's eyes, because there's a 1 in 3,000 chance or so that a baby will be born with a cataract, which is an opacity in the lens of the eye, and it effectively is like a blockage over that baby's eye, and we're looking to see that we can shine a light in and see that there's no cataracts there. And that's very important, because if that isn't picked up, then the eye will stop developing as a seeing organ. So really crucial that we would pick up on that problem. We move on then down to the nose, and we're looking to see that the nose is patent and the air can pass through the nose. Babies at this age, up to 6 months, they have to breathe through their nose. They don't really breathe through their mouth at all. So you can imagine that if a baby is born with a complete blockage of the nose, that is very dangerous for that baby, and the baby has to be whisked off to intensive care to try and open up that nasal passage. That problem is extremely rare. What is much more common is when you bring your baby home, you will have a problem whereby the baby will pick up little viruses. Their cousins come over, give them a kiss and cough and sneeze over them. They pick up a little virus, they get a runny nose, snuffles, the dry, warm air in the house leads to the mucus drying out and blocking the nose, and so those babies become quite congested. They go off their feeds, they become a bit windy because they're gulping air in while they're feeding. That's much more common. So a blockage caused by mucus, caused by viruses, is much more common. So I would recommend that when you go home, make sure you bring some saline drops with you, so that you use saline drops, squirt them into the nose to keep that nasal passage nice and clear, so that the baby can breathe easily and has no subsequent problems relating to that. We look then at the mouth, and we want to make sure that there's no cleft lips or cleft palates, which can sometimes happen in babies. Moving on then down to the chest, we have a look at the baby's heart, and we look and see that the baby's heart examines normally. Now what we find very commonly is that a baby has a murmur in the heart, and people sometimes will worry, oh, this means that there's something major wrong with my baby. That is very far from the truth. Really, a murmur is the sound of blood flowing through the heart, and it can be present in a perfectly normal baby. A baby's heart is the size of their fist, and it's divided up into 4, and the baby's heartbeat is going at 140 beats a minute. So you can imagine that with the speed of that heartbeat, you can imagine that it's very common to hear little squirting noises, whooshing noises as the blood flows through that tiny little organ. And that's what a murmur is. And as I say, that heart can be perfectly normal, can have no holes, no narrowings, no abnormalities whatsoever, but you can still hear a murmur. But lots of you here in this room will be told that your baby has a murmur. So what we do is we just watch these babies and we make sure that they examine well otherwise, and I'll go through some of those examinations later, and equally that they're feeding well, that they're gaining weight well, that they are thriving and not picking up any infections, because those are the signs of significant heart problems in a baby. But by all means, but certainly I would say that if someone tells you that your baby has a murmur, it means we need to watch your baby, but it certainly does not mean that there's a physical problem necessarily with your baby's heart. Moving on then down from the chest, we have a look around the belly button. The belly button itself, the clamp will still be on. This tends to fall off around day 5, day 7 sometimes. And when it does fall off, you're left with a messy, mucousy discharge area around the belly button, and that's entirely normal also. what is abnormal is if the normal skin that leads up to that belly button becomes red and inflamed and becomes red and raw looking and swollen. That is a sign that there's a bit of infection around the belly button. But again, that situation is extremely uncommon. Mother Nature has a good way of just making sure that these babies don't tend to get infections there. It does happen, but it's quite a rare occurrence. And it's much more common that you would see just a bit of discharge around that area. Now, sometimes there can be a relatively minor problem where there's persistent discharge coming out of that area 3, 4, 5 weeks down the road. And that tends to be a little persistence of the cord called a granuloma. And we sometimes use a bit of silver nitrate just to dry that off and to stop the persistence of the cord going on any further. And it tends to dry it up and heals up well then with minimal intervention. We move on then down to the baby's groin, and we have a look and feel for the pulses in the groin. This is important because there's a problem in babies sometimes where the major blood vessel coming out of the heart that feeds the body can be narrowed up at around the shoulder level, and this leads to weak pulses in the groin. And that is an important thing to pick up on, because the baby can be normal for the first week, 10 days, 14 days, and then can suddenly then get very sick. So it's really important that we would check this baby out and make, on a regular basis after birth, to make sure that we can feel good, strong pulses in the groin, so that we know that this narrowed blood vessel isn't happening. The next thing that we do is we look at the hips, and babies can be born with dislocated or dislocatable hips. This is where the hip joint is badly formed. Now, a normally formed hip joint has a socket, and then the thigh bone sits nicely into that socket. So we call it a ball. This is the ball here, and a socket joint. Now, sometimes babies are born whereby the socket, rather than being a good fit, is actually more like a disc, and so the hip can easily fall out of that joint, and that's where you get dislocated hips. It's important that that is picked up early, because if you don't pick that up and a baby is left with a dislocated joint for 6, 9 months and 12 months until they're walking, that hip joint is spending all that time not developing properly. Whereas if we pick up that hip is dislocatable and we fix that hip back into the joint properly, the hip will actually develop properly over the coming few months, and stabilization is achieved with very little intervention. Now, the thing about it is, the important thing is there are some risk factors for this. It occurs in about 1 in 1,500 babies, approximately, but it's much higher in a certain group. And the group that I would be concerned about would be those whose parents have had dislocatable hips. So not first cousins of the baby, distant relations. It really is about the parents of the child. If they were treated for dislocated hips, they should certainly get this baby's hips checked out a bit more urgently and a bit more completely. The other group that you would be concerned about would be babies who are born breech, so they're coming bum first. Those babies also need to be checked out more completely. Also, if you've been told throughout your pregnancy that there's not a lot of fluid around the baby, so the baby doesn't have as much room to move around and to be flexing their joints, those babies are more at risk. And similarly, if there are twins, where there's two babies squashed into the smaller space, again, they don't have much room to move around, and they're more likely to develop dislocated hips. So any babies in that group need to be checked more completely, and by that I mean have an ultrasound done of their hips at an early stage, because the examination only picks up about 70% of dislocated hips. So the ultrasound is more complete, and certainly if you have an ultrasound that shows that your hip is normally shaped, the chance of you developing a dislocated hip at a later stage is tiny. Okay, so very important that we would get those things checked out, and that's something just to mention to your pediatrician when you're getting your day 1 check of your baby. Um, okay, so the next thing is we move on down to the legs. And again, the other problem that you see very commonly is in-turning of the feet. So babies, when they're in the womb, their feet are tend to be flexed up like this. And so it's very common for babies, rather than for their feet to be straight out like this, their feet are turned in somewhat. They can almost clap their soles together. And that is very common, very normal. As long as you can bring that foot straight, that if you can stretch it into the neutral position, that is perfectly normal. If it's fixed and stuck in that position, it means that there's an underlying bony problem that needs to be intervened with, and to try and get that baby into the neutral position with their feet. You can see lots of abnormal postures in babies. I recall one occasion where a baby was delivered, and the knee was flexed up forwards, and there was lots of distress and upset among the parents, and obviously among the midwifery staff and everything, that this baby was never going to have a normal lower limb. And really all that had happened was that the kneecap had slipped to the side, and this had allowed the knee flex up the wrong way. And all we had to do was just straighten it, allow the kneecap slip back into the normal position, give the baby a bit of support of strapping, and then we saw the baby back at 2 weeks and at 6 weeks, and this baby was perfectly normal, had a perfectly normal lower limb. So the lesson is that often babies can be squashed into this womb, can get into abnormal postures, can have all sorts of abnormal postures and shapes, and just allowing them have the freedom of the wider world, things will often normalize and there'll be no long-lasting consequences. So that's your head to toe, and then obviously we do the weight, we do the head circumference, and we do the length, and we make sure that everything is appropriate. So that's your day one examination, and it kind of just picks up some of the things that we look for, some of the things that you might be told about, and some of the things not to get too worried about if somebody says to you that there's this problem or that concern that they have when they're examining your baby. So the next thing then is about minding your baby and care for your baby and so on. And obviously the first thing is around feeding. And what I would say, certainly more I'm sure has spoken to you today about breastfeeding. And breastfeeding is very important for your baby, and it is really something that I would strongly encourage. I think it's really important that you'd give it as good a go as possible in order to achieve breastfeeding. You know, I think that there's lots of supports out there to achieve breastfeeding. There's lots of breastfeeding support groups, there's family, there's friends, there's the midwives in the hospital, and there's the public health nurse who comes out to you. And all of these people are very helpful to try and achieve breastfeeding for your baby. And the reason it's so important is, I think, you know, is aside from it being nutritionally complete for your baby and being an easier way to feed at 3 in the morning, to be able to pick your baby up and give them a cuddle and give them a breastfeed, that's certainly a lot easier than working out all the formulas and sterilizing things and all these issues. So I think aside from those obvious things, there are other things that we get concerned about as pediatricians. And the big thing, I would say, is the boost to your baby's immunity. You've had all these infections before: chicken pox, measles, rubella, all these different things that can be damaging to your baby. And you boost the baby's immune system. You give them antibodies against those infections every time you breastfeed. And it comes back to when people say to me, when should I stop breastfeeding? I would say breastfeed as long as you can. The longer you breastfeed, the better for your baby, because each time you feed them, you're giving them another boost and another boost of the immunity that you have. So really important that you would try and breastfeed and try and succeed with that. That said, you know, breastfeeding doesn't work out for everybody, and that's an important thing to recognize, is that sometimes breastfeeding doesn't work out despite your best efforts. And it is a terrible thing for me to see a mum come into my clinic and they are distressed and upset, and they haven't bonded with their baby because they blame the baby over the fact that breastfeeding hasn't succeeded. The most important thing for you and your baby is that you bond well. and that you are comfortable with each other and that you enjoy each other, because that is the most important thing. Your baby will ultimately do fine on bottle feeding if breastfeeding doesn't work. But give breastfeeding the best go that you can, and don't give up too early. And if you are going to breastfeed, try not to supplement with bottles early on, because if you do that, you will fail in your breastfeeding. You won't have the milk coming in because the baby won't be hungry, and so you won't be stimulating the breast. So it's really important to give the breastfeeding a good go, at least for the first couple of weeks, if you want it to succeed. If you come in and on day 2, day 3, you're giving a few extra bottles, more than likely that breastfeeding is not going to succeed for any significant duration of time. So really important that you would give it as good a go as possible. Absolutely essential. But as I say, bond with your baby first and foremost. And you know, it shouldn't be all or nothing. It shouldn't be that you should be saying to yourself that if breastfeeding doesn't work, I'm a bad mother. That is the worst thing I can hear from any mother. I think that is completely the wrong message, and I don't think any of the breastfeeding advocates would recommend that kind of a message for in relation to feeding. The next thing is around bathing your baby, and often I get people telling me that you know, they've been told that they can't bath their baby every night, that they've been told that this is bad for the baby's skin. Something I just can't agree with. I think as long as you're doing the right thing by your baby and using the right products in the bath, I think bathing your baby every night is a lovely bonding thing to do with your baby. What I would recommend is emulsifying ointment or Silcox base. You can get massive big tubs in the pharmacies, and if you put a scoop of that into a cup, pour some boiling water into the cup, and pour that into your lukewarm bath water, that is a great baby bath. It is very protective on the baby's skin. You can use the Silcox and emulsifying ointment as a soap directly on your baby's skin. When you're finished that, you can take them out. Now be careful, because at this stage they will be quite slippy. Bring them over, pop them down, dry them off, and again you can use emulsifying ointment or Silcox base as a moisturizer afterwards. And I think that is a perfectly safe regime. It is safe for any baby, even if they had eczema, and so I would have no problems recommending that on a nightly basis for any baby. And as I say, it is a nice way of bonding with your baby. Just one thing I meant to mention about the feeding as well is vitamin D. Important that all your babies would get vitamin D every day for the first year of life. Really crucial. And we're seeing a re-emergence of rickets. It's particularly important in babies who have darker skin, because the vitamin D, we have plenty of vitamin D in our diet. It's just the fact that we don't have enough sunlight to activate that vitamin D in our system, and that means that as a result, we don't get the benefit of the vitamin D in our diet. So, and that is even worse in a baby who's got dark skin, because even less sunlight gets into your bloodstream through the dark skin to activate the vitamin D. So you need to take the activated vitamin D, and I know Maura has some of the samples here. So Baby Vit D3 or Abidec D3 are the vitamin D supplements that you need to use for your baby to make sure that they have normal normal bone growth. Sleeping is obviously really important for your baby. People often ask me, when will a baby sleep through the night? And I would say, it obviously varies between babies. One thing I would say is that it's very unusual for a baby to sleep through the night who's under 5 kilos or 11 pounds. Because I think a baby that size has enough fat on board to kind of draw in extra sugars to get them through any dips in their blood sugar through the night. So, you know, a small, skinny newborn baby is really not going to sleep more than 2 or 3 hours in a row. And I'd be worried if a baby that age was sleeping through the night. But certainly when they get to 11 pounds, you're more likely to see them sleep through the night. The big thing about sleeping is the back to sleep sleeping position. Really important that you put your baby on their back to sleep. That one measure has been shown to have improved the cot death rate by 50%. So there's no question You leave them on their back to sleep. You know, by the time they get to 4 or 5 months, when they're able to roll over, you don't need to worry. A baby is very unlikely to run into problems if they're able to roll over themselves. You know, we don't recommend using pillows. Babies' necks are very flexible, so a baby flexed forward like this is very likely to obstruct their airway if their neck is flexed, because it's so compressible around this area. So really important that you would just have the baby flat on a mattress in the Moses basket. That's how a baby sleeps, on their back. Another thing is that you make sure that you lay them down with their feet down at the end of the Moses basket, because when they move at night time, they will come out from underneath their blanket. If you have their head up at the top and the blanket up to here, when they move, they can go down underneath the blanket. So really important that you would make sure that you have their feet touching the bottom of the blanket and nothing covering them. What do they wear when they're sleeping? They can wear a vest and a baby grow, and then they can have a sheet and maybe another blanket on top of them if it's very cold, but that tends to be enough, you know. And the room, you know, shouldn't be overly heated. I mean, you shouldn't be hit by a wall of heat when you walk into a baby's nursery. It should really feel quite normal walking in. It shouldn't be cold, but again, it shouldn't be overly warm. Very important that a baby sleeps on their own. Don't sleep with them in the bed with you, because you are huge compared to them. They are a tiny little body. Even just the heat being given off by your body can be enough to overheat them and create major problems for them in terms of survival through the night. Never mind the fact that you could easily overlie them and suffocate them. So it's really important that you wouldn't sleep in the same bed as your baby. That is very important and crucial. The other issue is around is just the learning curve around caring for your baby. You know, it is a very steep learning curve for young parents, new parents, to be looking after a baby, and there's a huge amount of things to be aware of and to try and understand. And really, there's a few things that I would emphasize as you know, benefit to you in terms of being aware of when to worry and when not to worry. Some of the common problems that you will come across will be things like reflux. So reflux is where food goes into your baby's tummy, but then instead of passing through down as poo, it comes back out as vomit. Okay, so they feed and then they puke, and they're kind of little pukey babies, constantly spilling, constantly vomiting. That is normal. If I was to do a study looking for reflux, radiological reflux, an X-ray on your baby at day 1 of life, I'd find it in every single one of your babies. Okay, so you have to realize that reflux is a normal phenomenon. Okay, there's another phenomenon altogether which is called reflux disease, and that is babies who vomit up blood. So where the acid has come out of the tummy, has gone up into the gullet, has burned the gullet, has left red raw areas there, and the blood has come out in the vomit. Now when you see this, it won't be fresh blood. It tends to be, looks like ground coffee, because the blood has been altered by the acid. So it looks like coffee grounds in the vomit. That's reflux disease. The other group are the babies who vomit so much that they lose weight. Okay, that's again reflux disease. And then there's another group who are very irritable, very cranky. They've got heartburn, they're distressed from the vomit. And that's another group where we treat some of them, but we don't treat all of them. It depends on the severity of the symptoms. And that is reflux disease, and we use various things like thickeners in the feeds. We use antacids, we use things like Gaviscon to manage these babies. So again, it's a very common problem. We probably over-treat it. We try and minimize the amount of treatment that we give, because we know that this is ultimately a normal phenomenon. I don't want to be over medicalizing your babies if we can avoid it. Um, the next thing that you'll see is constipation. So milk is quite constipating. I mean, if you came back into me at 2 years of age with your baby and you told me that your toddler now was drinking 2 pints of milk a day, without you saying another word, I'd be saying to you, I guarantee you he's constipated. So you can imagine these little babies who are drinking, 700 mils, 800 mils of milk a day, when they're getting up to kind of 3, 4 months. They do get quite constipated. It's quite normal for them to get constipated. And constipation to me isn't necessarily a baby who goes for a poo every second or third day, because there are some babies who are quite happy to do that. Constipation to me is a baby who is straining to go, who is going red in the face, pushing, and is desperate to go. And you're constantly checking the nappy, going, "This is it. It's gonna have done it finally," and there's nothing there. That's a constipated baby, or a baby who is passing little hard pellets like little rabbit poos in their nappy, or a baby who's got a bit of blood in their nappy from the hard poos tearing around the bum. That's a constipated baby. So we're not looking for a goal of a baby passing a poo every day necessarily. We're looking for a baby who is comfortable going. So, we do see a lot of babies who are constipated. We do treat them with Movicol and lactulose and simple laxatives for babies. So that is quite a common problem, and certainly easily managed. Other issues that you'll find, certainly you'll see a lot of babies with eczema. So eczema is dry, red, inflamed skin, and it's very common for babies to have dry skin. I think if we go back to the bathing regime, I think if your baby has a bit of dry skin, so a bit of flakiness, but not too much redness, I think it's perfectly reasonable to manage them with excessive moisturizers, and that certainly gets on top of a lot of their eczema or dry skin problems. Equally though, babies can be quite distressed with eczema. If you or I have an itch, we can just scratch, but a baby isn't able to localize pain or itch. So you can imagine they are quite distressed and quite upset when they get this itch and they can't scratch it. So they can, be quite irritable babies if their eczema is bad enough. So I would certainly use some steroid ointments on babies' skin to control it, but only in the group where we found that they were very unwell. And then the other problem would be things like colic. Colic is defined as a baby who has 3 hours crying a night for more than 3 nights a week for more than 3 weeks. So in other words, we don't know what it is. We define it as a syndrome of symptoms, but we don't know what the cause of it is. Now we are getting to understand that some of it is an intolerance of food, and I might talk about that now. If I was to treat 100 babies who had colic with a pre-digested feed, 70 of them would get better. So in other words, 70% of babies with colic have a cow's milk protein intolerance. Okay, and what we do for those babies who have an intolerance is that we give them a pre-digested feed to help them digest it, to make it easier for them, so they aren't as windy, aren't as upset, and they settle down a little bit easier. There's another group of babies who get lactose intolerance. This is extremely uncommon. About 1 baby in 100,000 is born in Ireland with congenital lactose intolerance. You wouldn't believe it for the number of lactose-free feeds that you see out there in the pharmacies and in the supermarkets. But lactose intolerance is extremely rare. Cow's milk protein intolerance, which is a protein intolerance, is much more common. But the lactose intolerance, which is a sugar intolerance, is extremely rare. The lactose intolerant babies present with very profuse diarrhea and acidy poos which burn the bum, leave them with very bad nappy rash. So I do use it sometimes, but it is extremely uncommon. It's probably commoner in babies who have suffered an episode of gastroenteritis and they're left with a short period of lactose intolerance where the gastroenteritis has stripped away the lining of their gut, and they then can't digest the lactose that's in the feed. So transient lactose intolerance is quite common, but a baby to be lactose intolerant forever and a day is extremely rare. So coming back to the group of colicky babies who are not intolerant of any feed, this is a difficult group to manage because there is nothing that we can offer really to improve them. They are just babies who are unsettled, who stiffen, who don't benefit from feed changes, who don't benefit from putting them on medications for reflux. So in that sense, they are difficult. All we can do is manage them with more behavioral management things. And the things that I would do to try and settle those babies would be baby massage. I think that is a nice thing again to do with your baby, and there's a number of people offering baby massage classes. So I think that is something that is beneficial for any baby, and it's a nice bonding thing to do between mum and dad and baby. So baby massage certainly helps these babies. There's a swaddling, and I think I'll let Maura demonstrate the swaddling technique that I have for babies. Babies, for 9 months in the womb, they've been tucked up in a really tight space, and they like that. They like being squashed into a small little space. They don't mind it. So the swaddling allows them just be warm, be controlled, and I think it just helps them sometimes to get over their upset. And I think the other thing that we use for the colicky babies is a lot of background noise. So a lot of white noise. So even just a loud radio in the background, making all that white noise in the background, that is enough sometimes to just calm a baby down and let them be more relaxed. But I won't lie to you, the babies who have colic and don't respond to anti-reflux medications and don't respond to one feed change are difficult to manage. I do think that you need to be careful that you don't get into a situation whereby you're changing your baby in everything that they do. There's nothing more difficult for a baby if they are being given a different feed every week, if they're being given a new medication every week. And I certainly have seen babies who come to me at 8, 9, 10 weeks of age, and they've been on 6 different feeds. They've been on Gaviscon, they've been on other medications, they've been to the cranial osteopath and all these kind of people. And there's no wonder that the baby is upset. And I think if we'd focused on some of the more simple behavioral management things, if we'd listened to the story and worked out what the problem was and realized that it was very unlikely that this baby had any reflux, or maybe treated some mild constipation or something else along the way, that we could have got to an answer much quicker, we could have ruled out things much quicker, and we could have focused on the things that were going to make a difference for the baby a lot quicker, and not put them through a whole load of unnecessary changes. And that's my kind of feeling around managing babies and behavior and so on in the first few weeks of life, is to try and get the right mix of treatments and observation correct, so that we don't over medicalize babies. The vast majority of babies are healthy little babies, and we just need to get to know them, get to understand them, realize what we need to do to make them more comfortable. So that would be my feeling on it. What about the other thing, those are some of the common problems that we would see with babies that are benign, that are easy to manage, that we just need to put them on a certain regime and they will improve. But when do you know that your baby is sick? That is obviously one of the things that new parents worry about most. And what I would say is, certainly in the first 6 weeks, any temperature in a baby is grossly abnormal, okay? And it's very different from the 2-year-old who walks into your clinic with a bit of a temperature, who can tell you a certain amount about how they're feeling, and the parents know them that bit better, and they're a bit bigger and they're a bit more. You can understand them a bit better, and interrogate them a little bit better and try and work out what the source of this infection is. But a little 4-week-old baby comes in with a temperature. It's very difficult to be reassuring in that environment. Now, most of them will have a very minor viral illness, but a significant minority of them will have a more serious illness. I mean, if you take the 2-year-old example, 95% of 2-year-olds with a temperature will have a virus running through their system. For a 4-week-old baby, a 2-week-old baby, a 6-week-old baby, that figure is actually only 70%. So in other words, 30% of those babies will potentially have a bacteria coursing around their veins, causing a temperature, and they need antibiotics. So in that instance, I think that it is not something that, for example, a GP can outrule that there's nothing serious going on here in a 4-week-old with a temperature. So they will refer them on into the hospital for more invasive tests. And if I was seeing a 4-week-old with a temperature in the emergency department in Tallaght, I would be taking bloods, I'd be taking a urine sample, I'd probably be doing a lumbar puncture, I'd be doing a chest x-ray, because I can't examine that baby and find the focus. It's extremely difficult, and I wouldn't expect my GP colleagues to do that either. So it's one of those things whereby when a small baby gets a temperature, you really are looking at an attendance at hospital to try and find out what this problem is. The next thing, I suppose, is to remember that you will know your baby very well. And there's an adage that I would say to my junior doctors in the emergency department in Tallaght again. I would say that if mum is worried, we should be worried, because you know your baby better than anyone else. And for sure, you can come into the emergency department and you could be concerned about your baby, and we could look at the baby, examine the baby, and everything could be normal, and we can explain there is nothing to worry about here. As long as we can explain it to our own satisfaction, and most importantly to your satisfaction, as to why what you are seeing with your baby is okay, then we can reassure you. But if you are not being reassured by somebody, you should make sure that you get a second opinion, because you know your baby better than anyone else. And I think any change in the behavior of a small baby is significant. They are rarely, if ever, putting it on and trying to get attention from you. If a baby changes from 4 weeks and suddenly becomes a more cranky, irritable baby, or becomes a sleepier baby, that is significant. And I think it is something that you should bring to the attention of any doctor who's looking after your baby. The kind of change of behaviours would be, as I say, more sleepy, more irritable, not feeding as quickly as normal, not a bit slower with their feeds, vomiting a bit more, colour isn't as good, not as interactive. All of those things are things that you should bring to the attention of the doctors and get an adequate explanation for it. And there may be an explanation, and that's fine, but make sure that you do get an explanation that you're happy with when you go in and see doctors in hospital or in the GP practices. The other thing, I suppose, is the other things that you can see skin rashes in babies. So we've talked about eczema. It's very rare to get any dangerous looking skin rashes in small babies. They tend to be in older babies. These kind of non-blanching rashes, where you roll the tumbler across, you don't usually get those worrying rashes in small babies. They tend to be a bit older. So rashes, again, I think will need an opinion by a doctor, but they often are not very significant, and certainly not a sign of any kind of impending distress for a baby. I'd be more concerned about the pale baby, the lifeless baby, the baby who's a bit floppy compared to normal. That's when you really are seeing a baby who is sick or unwell. Um, Lastly, we'll talk just about the situation whereby you might come across your baby and feel that they are very acutely unwell. So you come across your baby and they are um, not showing signs of life, or a bit limp or lifeless. Um, it goes back to what I was saying about the baby in delivery, whereby they can come out very limp and lifeless, but we don't need to do much to bring them round. Often in that situation at delivery, we just need to dry them off and give them a puff of air into their mouth, and then they suddenly perk up and start crying. And that is the same for you when you're at home with your baby. It's much more likely to be a primary cessation of breathing, a respiratory arrest in a baby before anything else. Remember that their hearts, even if they've got a hole in the heart, their heart is essentially normal and healthy. But what can often happen is that the baby will have a respiratory obstruction or some kind of problem whereby the breathing is arrested. And it goes again to situations like where the baby's head is flexed forward and that blocks their breathing. If the airway is blocked, they will stop breathing. Again, if there's a lot of mucus in the nose, they can have breath holding spells. So all of these things are much more common than a primary heart problem in a baby. And the reason this is important is that you need to be aware that you can, when you see your baby and you think that they're pale and not breathing, and it sometimes can be very shallow breathing, but if you think they're not breathing, then what you need to do is you need to give them 2 strong breaths into their lungs to try and get them breathing again. And that often is enough. So what you do is you put your mouth over the nose and the mouth of the baby and blow. And give them 2 rescue breaths so that their chest rises. And that is often enough to get them going again. And once you see a baby moving, then you don't have to worry about their heart. If the baby starts moving, their heart is going, because that's a sign of life. If a baby has a sign of life, then they're not going to have any heart problem. Their heart is going again nice and fast at that 140 beats a minute that we spoke about earlier. But obviously, whenever you come across a baby and you have to do any intervention like that, you need to be bringing them straight into hospital and getting them checked out and at least observed overnight. But this is not an unusual situation. If you give them 2 breaths and they are still pale and lifeless, the next thing is to give them chest compressions. And really, you're looking just below their nipple line. You're putting 2 fingers in the midline, just below their nipple line, and you are giving them compressions like this: 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9, 10, 11. And we go all the way up to 30, okay? You give them 30 compressions, nice and fast, and then you give them another 2 breaths. Now, there is no point you being at home doing this with a baby unless somebody is rushing to you, okay? So it's very important that you make the call to 999. That you are going to be able to do nothing at home with your baby. You can certainly give them the 2 rescue breaths. You can give them 30 cardiac compressions. You can give them another 2 rescue breaths. But if you have not rung the ambulance at that stage, you really should go off and make that call, because it's going to be the advanced interventions that it will have most chance of saving your baby's life at this stage. As I say, I think the 2 rescue breaths are the things that are going to make the most difference. So I do that before I do anything else. Unless there's someone else in the house, you can literally just make a call downstairs for somebody to come and help you. But if you're on your own, 2 rescue breaths and then make the call, or 2 rescue breaths and make the cardiac compressions are most important. But you do need help, and you do need assistance. So make sure that you don't hold back on that. It's not a nice way to finish the talk, but I think it is important that that is a strong message in this talk for you, that you know how to look after a baby and when to be concerned. Um, in terms of checks for your baby, I think that it's really important that you would get the checkup done at birth, so the day one check, and then I think it's useful to get a 2 week check and then a 6 week check. Um, though those checks are done in our practice, in the children's practice in Beacon South Quarter. We provide actually a 12-week package for parents who can come as often as they want for 12 weeks for €280. It covers all your visits, covers everything in terms of your attendances at the clinic, and it also includes the newborn hearing screening that we do for babies. And I think that is everything that I wanted to talk about. What will happen now is I think Maura will take some questions. If you have any questions, Maura has been to obviously plenty of these talks, has heard my answers, she tells me that she's learned a huge amount. So this is your chance to test her and see if there's anyone who has any outstanding questions. I can certainly engage in some discussion. Maybe if we had I could send out a group email to people. If there was any question that Maura felt that she wasn't able to answer, I could send out a group email to people to explain it in a bit more detail. But I think Maura will be able to answer all your questions. But if not, I'm happy to discuss with them again. Apologies that I could not be there today. And best of luck and best wishes with the rest of your pregnancy and with your babies in the near future. Thanks very much.